So, good afternoon everyone and welcome to this webinar on neck pain. Today we're going to be specifically discussing, is strength the missing link? Neck pain is one of the biggest problems within healthcare and manual therapy is the most common treatment for this, but should we be incorporating more objectivity into assessment of neck strength and then the strengthening itself? I'm Andy Thomas and Director at PhysEquip, and I've been working with BTE Technologies for over 13 years. And they produce a system which offers precisely this objectivity, which is the MCU multi-cervical unit. The format for today will be our speaker, Jeff Johnson, will present the latest evidence, and then we will have a Q&A. So hopefully you'll all have lots of questions at the end of it. So please put this in the section below, and we will do our very best to address these. Today's presenter is Jeff Johnson. He's an athletic trainer who's worked clinically with elite sports institutions for several years. And he's been working with BTE for around 7 years now as their clinical applications specialist. So really pleased to have him joining us all the way from the US today. So welcome, Jeff, and I will now hand over to you.
All right, good morning. It's almost happy hour your time, but I still have to wait. Thanks for having me, Andy. My name's Jeff Johnson, and as Andy said, I'm a certified athletic trainer with BTE. I've been doing this almost 8 years now. And my first real exposure to the MCU was when I first came along with BTE. And since then I've been able to travel the world and learn more from clinicians, how they're using the system, as well as some of our in-house experts on the unit. I'm going to talk a little bit about neck pain before jumping more into the MCU. Just one moment. And if you don't mind, I'm sorry, we have a new puppy, so that's in the background. All right, so neck pain. As Andy did mention, neck pain is a huge problem. It's not something that's isolated to just one population. It's not something that's isolated to just one region. It is a huge problem around the world. Just a few stats that I'm going to throw out to you. About 70% of us will at some point in our lives experience neck pain. That neck pain may be very short-lived, or it may be something that we deal with on a chronic basis. Hopefully, whatever that level of neck pain may be, it's something that is not going to have a huge impact on day-to-day life and function of someone. It is, in the US, it's one of the top 5 leading causes of disabilities. It is going to have a substantial financial impact on the medical system. That number is now well over $100 billion in the US as this stat came about 4 years ago. There are more than 16 million visits that occur, so this also has an impact on the medical system with just getting people in and out of the doctor's offices. There are times that I've been exposed to some of the orthopedic surgeons here that work with neck pain, where a person who needs to be evaluated may have to wait 2 or 3 months to get evaluated. So that's more time with pain, more time with possibly disability. And unfortunately, ladies, you are more vulnerable to experiencing neck pain, countless reasons for that. Some of it can be hormonal, some of it can be physical changes that occur, especially if you've had children. So we're going to look at neck pain in really one of 3 levels. It's going to be acute, very short-lived. It may be something just from sleeping in a bad position. You woke up one morning and you're very uncomfortable. Subacute neck pain, that's going to be going on for less than 3 months, but it could start to have an impact on more day-to-day functions, may have an impact on your job and ability to do things that you enjoy, golf, tennis, football. And then chronic neck pain. 30% of these cases, of neck pain cases, are going to turn into chronic. And these are the ones that are greater than 3 months. And you'll see sometimes cases, as you all probably know, where neck pain can go on for years. My mother-in-law is one of those who has dealt with neck pain since I've been in the family. That's been 17 years. So it certainly is a problem that it's not very quickly and easily resolved for some individuals. And there's a direct correlation between the duration of the neck pain and how long it's going to take to resolve. So the longer that you have pain, the more issues that you have, the more likely it is that you will continue to experience these problems for a longer period of time, and that it will take longer for you to treat that and to recover once you're starting to receive therapy. So there are various causes of neck pain. Headaches, I think a lot of us are probably very familiar with. We have them ourselves with just day-to-day stresses of life, working with patients. Sometimes if we're working more manual therapy, if we're doing our own massage on soft tissue, that can create tension in our own bodies and we can start to experience some of these headaches. These cervicogenic headaches, they can create the neck pain, and then the neck pain can create the headaches. So it's kind of a little vicious cycle that will develop. The headaches can be a result of inflammation. Maybe the traps or the sternocleidomastoid, maybe you have some inflammation there. That's going to create tension maybe in the jaw, and then that can create some more headaches as well. Most people will accept that the deep cervical flexors in the neck, that those are the weak and the most involved with cervicogenic headaches, and those are the muscles that we really want to isolate with any form of therapy, in particular with our MCU. Torticollis, that's going to be the shortening of the sternocleidomastoid, possibly on one side, it could be on both. That's something that needs to be addressed earlier in life, because if it's not, then by the time you become an adult, that will have some greater impacts. The big one is muscle weakness and imbalance. You know, where the head is supported on this very, very thin tree trunk. The head weighs in a neutral position approximately 12 pounds. And if the muscles that are surrounding those tree trunks aren't strong, then we could certainly have an area where we have a lot of movement of the head, a lot of instability that occurs. Muscles, they don't work in unison, and so we can have a big imbalance that exists there. We are big on promoting symmetry between the left and right, and symmetry between agonist and antagonist. We don't want to see unacceptable relationships with those symmetries. Also the shoulders. Think about the amount of time that we sit at a desk, or if you're on a train on a daily basis, or if you're carrying a bag. You know, for instance, me, when I travel, I'm always carrying about a 10-kilo backpack, and that weight sits on the shoulders. There's a lot of pressure that's being put on my traps and my rotator cuff. So if you're one of those that carries a bag like that, you certainly don't need to ignore the strength of the shoulders and the movement of the muscles that occur for the rotator cuff, as well as the muscles around the scapula. So various reasons why we're going to have some cervical pain. Aging, that's a big one. We can't do anything about aging. All we can do is treat some of the consequences of aging. We can make sure that we're strong as we're younger, so that as we get older, the more fast twitch fibers we lose, the more quality fibers that we lose, that we at least have more there. As we start to lose them, we can be in a little bit better shape. Trauma, I'm going to hit a little bit of that in a moment. Trauma associated with motor vehicle accidents, that's probably the biggest that we'll see. Sports-related trauma, that's common as well. And then just day-to-day trauma. Maybe you're at work and something hits your head, or maybe you fall on the ice and slip and create a whiplash-type mechanism there. Posture, that's a big one. Once again, those of us that sit down for a long period of time, we're going to be more vulnerable to this. If you're one that you're fortunate enough to be standing up and moving around, likely your posture is going to be a little bit better, but we certainly want to look at posture, and posture can be a big influencer on having neck pain. Our job, what do we do? Are we someone that is looking up? Are we looking down? Are we rotating our head often? I was at an employer a couple of years ago, and I was looking at one particular job where this individual, for 15-minute intervals, they would be doing everything from the right side above their head. They'd be pulling down this plastic and then rotating. So their job required them to do this one repetitive motion where they were looking up. The nice thing is they were looking up, so they weren't getting into a flex position. We find that most people have issues when they have too much of a forward head posture. But in this case, they were looking up, but they were also rotating. So we had to look at their job being a contributing factor to other types of hip and back injuries. Another one is texting. Man, we've all seen this when we've been just in public, and the number of people that are looking down. And the longer that you look down, there's going to be a consequence at some point. I can't imagine that the teens of now, when they get into their 60s and 70s, I wonder what type of neck problems and back problems we're going to see with that population. But certainly that's something that we would like to address with any patient that we see that has neck pain. We want to talk to them about good habits. You know, when you are using your phone, how are you texting? Are you looking down, or are you getting your phone a little bit more upright? So balancing a bowling ball and a stick, it's always a nice metaphor to use. If you have a thin stick and you try to put a bowling ball or any type of ball on top of that, what's going to happen? Well, it's going to be some wobbling going on. That's where the muscles come into play. So strengthening is a huge piece of the puzzle for treating neck pain. So briefly, we'll go over the most common type of trauma that we are going to work with, and that's going to be a motor vehicle accident. We have the whiplash mechanism, which just explains the manifestation of the injury. It doesn't necessarily define the injury, it's just the mechanism of. The WAD, whiplash associated disorder, that's going to be all the problems that are going to then come about from this type of injury. What we see here is at 50 milliseconds up to 200 milliseconds. This is a very brief moment in time, but there's a lot that occurs in the spine. If you look at all of these different head graphics here, you'll see all of the changes of position of the cervical spine. A cervical spine is not meant to be straight. And then when it goes from a straightened position to an S position, we're going to start to see some trauma occur within the ligaments and possibly within the spinal cord itself. The real key is between 75 milliseconds and 150 milliseconds. That's when most of the physical damage is going to occur. And those can be countless injuries that occur to the structure of each disc, to the vertebra themselves, to the muscles, ligaments, tendons. With whiplash, you're going to get headaches, you're going to have double vision, possibly blurry vision. Dizziness is a big component of this. Muscle weakness is huge as well. We'll see people when they present into a clinic following a motor vehicle accident that there's substantial weakness within the spine, the cervical spine, especially within the flexors. And I'll show you some graphs of how we can see that in a few minutes. Up to 60% of those who are hit from behind are going to experience these symptoms for 6 months or greater. That's a lot of time to be dealing with these symptoms. Typically people that have a whiplash, they're going to need medication. They're going to be possibly out of work. This is going to have a huge impact on their day-to-day lives. And as you can see, it has a $35 billion cost with rehabilitation and legal challenges. And that number might be a little bit conservative, actually, when you look at some of the other long-term ancillary costs that can come about from this. So how are we going to evaluate it? That's the big piece to this. So you get a patient that presents to you, maybe they've already been to a physician. The physician has said that this person has neck pain associated with an accident. What do you do? Well, there are multiple ways that we can evaluate it. Probably the most common is we just look at a person, we take a history, what happened, we look at them, and then we start to move their head around. Maybe we actively tilt their head. Maybe we actively put them up into extension and flexion. And then we're going to do manual muscle tests. That's very common. Manual muscle tests is just a very small isometric contraction. In most of these cases, the evaluator is going to be stronger than the individual who's being tested, but you still have a very poor inter-rater reliability. You're not going to be able to detect very small differences. So if a person's able to apply for left lateral flexion 4 kilos of force, but on the right side 5, you may not be able to quite experience that. You'll be able to maybe say that's a 4 out of 5 or 4+ out of 5, but you may not be able to really see that small difference that exists. Also, the ability to put someone in the correct position. If we test functionally, and for the cervical spine, the functional position is upright with the head up, not side lying, not lying down in a supine position. We need to evaluate in an upright position. Another thing that we're going to use is questionnaires. Questionnaires are going to be like the Neck Disability Index, the symptom intensity rating. These are going to be scales that a person is subjectively answering questions to. So one person, their pain tolerance may be very high, and other ones may be very low. So you may see an NDI score of one person be 50% greater than another, even though the other person has actually more functional problems. But it's just a piece. We want to see what the person perceives this problem as being to themselves. Your more expensive and innovative types of evaluations are going to be the X-rays and the MRI, CTs. The X-rays are going to show more of the spacing in between the vertebrae. They're not going to really show anything soft tissue. So you'd have to revert to an MRI or CT scan to be able to look at the soft tissue, the vascular supply. Maybe there's entrapment of nerves, entrapment of some vascular tissue as well. But key is, how, after all of this, how does that apply to function? What's the impact on the person's life? So when you treat this, what most people are going to do is they're going to look at the symptoms. We want to calm down the symptoms. We're going to be doing a lot of treatment that consists of like electrical stimulation, maybe some massage, maybe some dry needling, things like that. But neck strength is going to be very important in the long-term rehabilitation of this individual. And modalities certainly can help, medications can certainly help, but they're only just briefly putting out the fire. They're not preventing this from becoming a bigger problem at a later point in life. So as mentioned, manual therapy, that's going to be one of the most common ways that you're going to treat this condition, as Andy mentioned, as most of the literature shows as well. Massage, it feels great. You're going to possibly get some temporary reduction in pain. It could be cost prohibitive. Here in the States, if we go and get a massage, if our insurance doesn't cover it, it's roughly $100 per session. You may need 6 or 8 sessions of that to really experience any type of significant benefits. So that can be very costly. Also, manual therapy, it can exacerbate symptoms because mentioning the side lying or the supine position, when you have to get up from that position, that creates extra force or extra stress on the muscles of the neck. And that could be an exacerbator of more symptoms. So we can't always put a person in a supine position, or even a prone position for that matter, and just touch them and be certain that when they get up that they're not going to have worsened symptoms. Hot and cold therapy. Hot therapy is used all the time. So many people are going to have at home an electrical hot pad. May have even some better hot packs that have the clay inside of them, moist hot packs. Those are very cheap. They're easy to apply. They can be short term. They can help reduce some muscle spasm, but it's not a long term effect here that's going to necessarily make the neck stronger. Dry needling. This is something that if you all are doing it, or if you've had it done to yourselves, you've probably seen some good results. Dry needling can be very helpful, especially when incorporated with physical therapy, with functional exercise, with movement. Dry needling works really well with that. Electrotherapy, ultrasound, laser, shockwave. These can be great ways to reduce trigger points. I know with shockwave in particular, that has some really good data for decreasing the spasms within the trigger points of muscles in the neck. And we reduce that just by 50%, and we're gonna be more comfortable. So certainly use those as needed. But the key still is strengthening. We have to focus on strengthening. If a person is maybe too weak in the beginning, you can do some isometric exercise. Isometric strengthening does have its advantage. You can't use it long-term because in order to improve the full function through the full range, you would have to focus on each individual angle isometrically. So when a person is tolerant of that, have them do some isotonic exercise. And key here is functional. What is the functional position for strengthening the cervical spine? As I mentioned, it's sitting upright and it's moving the head this way. And there's a way of doing that, and you'll see that momentarily. I mentioned the bowling ball on a stick. So we got to work on the muscles that are surrounding that stick, make sure those are nice and strong, that they're symmetrical with the muscles on the other side, that there's good balance between the flexors and the extensors. Yes, the extensors are stronger, but if we see that the extensors are 4 times stronger than the flexors, we have a large gap in the symmetry between the agonist and antagonist. And the more of a muscle weakness we have, the more of a joint instability issue we have. And as we know, a muscle can't generate its greatest force unless there's stability. You need mobility, stability, and those are precursors to strength. So you've got to focus on making sure that there's a good, stable platform, and we can do that by working on the strength of the muscles. Countless studies here that are showing that that muscle strength is important to people who experience neck pain. There's countless other studies that exist. If you would like to go onto our website, you can see some of the specific evidence-based studies that are for our products, as well as some references for some support references for these conditions as well. So once again, ways that we strengthen the cervical spine. Manual therapy, that's one. We just put our hand on a person's forehead and have them move through range. That can be very easy for you to do. You're hands-on, gaining the confidence of your patient. The downside to that is that there's no objective data that's being presented after each treatment. You're not going to be able to see the subtle differences between day 1 versus day 2. You can't necessarily look at the quality of the movement. We all have very good hands, and most of us in this profession, we've done it for long enough that we're very good at giving accurate data on a 4 out of 5 or 5 out of 5, but we may be struggling with really pinpointing that difference. And from a 0 to a 10-degree rotation position, what's the change that exists there? One of the most common ways that we'll see people actually strengthen is with TheraBands. I see these in pretty much any clinic that we go into. These TheraBands can be hooked up to a wall, they can be hooked up to a door. I've seen these little ladder contraptions with hooks that have different TheraBands at different heights. You'll also see clinicians, they'll give TheraBand exercises for a person to take home. And as you can see from the small picture, a person has to really get into the correct position to be able to do the TheraBand exercises on their own. That's challenging. I don't know if you all have tried to do that on your own, but I'll play around with it every now and then with my little TheraBand that I have here. And I can't always get into the ideal positions, but something's certainly better than nothing. But we wouldn't want to use TheraBands as being the long-term standalone way to do strengthening exercises. We probably have focused on doing some chin tucks. We always say you make a double chin when you're doing this particular movement. We want that person to get their ears over their shoulders, try to get those traps involved, those deep extensors, flexors involved as well. The thing with this is if you're just telling a person to do this at home, then what's your involvement? Do you need to continue to see them in the clinic? Are you really going to be able to document progress? Or are you just going to give them these little self manipulations that they can do at home? And then there's some contraptions that if you do Google search, you'll find some crazy types of harnesses that people will put over. I can't imagine that this guy does anything more than extension and working on the traps. He's working on the big muscles. He's not doing anything for those small muscles. And I've not quite seen anything like this in a clinic, but every now and then in a gym, you'll see some fun contraptions. So how does BT focus on neck strength? Well, we do this with the multi-cervical unit, the MCU. And a couple of the quotes here, as the title of the presentation is it the missing link? The founder of the product, Dr. Donardis, a clinician in Australia, he called the MCU the missing link. He struggled on finding a way to get people in a functional position, strengthening the cervical spine. And so he developed the MCU. We picked up the technology and we made it even better. But he has called this the missing link to cervical rehabilitation. He has seen excellent results. And since it's been released to the worldwide market, we have countless case studies and people who have dealt with acute and chronic neck pain where the MCU has been introduced. One particular clinician here in the US, he found so much success with it that he actually had to get another one. And both of those devices are used all day. He will have people that will come in from 100 kilometers just to use the MCU. So what exactly is it? Well, it is a medical device and it's going to be used to isolate the function of the cervical spine. We're going to look at isometric testing. You can even use isometric exercise with the MCU as well. You can isolate every position from 0 to 90 degrees at every 5-degree angle. So maybe a person is very good in a neutral position, but they struggle with rotating their head beyond a certain point. If you're a truck driver, if you're someone who spends a lot of time on the road, then you're going to be looking in your rearview mirrors, you're going to be looking in your side mirrors, and you need to make sure that we have good rotation. So if we have good rotation, but we don't have strength, we may not be able to stay in that position for a very long period of time. So that may start to have an impact on our driving ability. We're going to look at range of motion in all 3 cardinal planes. We're going to assess it there. We can do 22 minimum isometric tests, or we can even add to that. Like I said, you can do every 5-degree angle for flexion left, flexion right, extension left, extension right, lateral flexion left, lateral flexion right. We can do countless isometric evaluations with this device. And the key here is that you're going to objectively look at the strength of the cervical spine, and you're going to be able to show your patient, you're going to be able to show case managers, the legal team, how this injury or how this condition is impacting this person functionally. Over 90% success with the patients that have been surveyed who have used the MCU, I would say that's pretty good. And at this point, roughly 20 years, that number is quite high. The clinics that use this, you're going to have MVA clinics, clinics that specialize in the spine, the entire spine. We have quite a few of those here in the US. Physio clinics, they are going to be the people that are going to be using this as well. We don't see as many just straight physio clinics using this because I think there's still a little intimidation with the cervical spine, and we'll come to that in a bit. This is used in elite sports. We have some sports programs here in the States and abroad that use this to assess and treat their rugby and their American football players. We're seeing a lot of MCUs go into military sites, and there's a couple of studies that I can reference for you in this. In chiropractic clinics, they're seeing great success with this because chiropractors are typically the go-to for when people are having neck pain. They're not really sure what to do about it. It's been there for a while. Maybe they went on to the internet and found some exercises, and those exercises didn't help. So They may go to a chiropractor thinking that only a chiropractor is the person who could treat that. So we see quite a few of these in chiropractic clinics. Aging population, so skilled nursing facilities. This is a place where we certainly want people to maintain good cervical strength as they're aging. And as we already know, with aging, we're getting weaker. So, hey, let's start implementing this with the older population as much as we can. And it's used heavily in research. So just a couple of comparisons of how MCU is used versus other methods. MCU versus TheraBand. Here we have a case of 32 people were treated with MCU versus TheraBand. This was a 10-week training program, 2 visits per week. And within the results, we see that we saw improvement with the TheraBand group, but when you compare that to the group who exercised on the MCU, these are significant differences. These are not minor differences, but it shows that the MCU was the most effective strength training modality to increase isometric neck strength. We have another one, here we have MCU versus heat. Most people, when they have a back injury, neck injury, they're going to go on to the website, Dr. Google, right? Just type in your symptoms and Google will tell you what you have and how you want to treat it. And a lot of times they're going to say, go to heat, go to cold, self-massage, things like that. But in this particular study, they looked at 145 subjects. They were all treated with either strength training and infrared treatment, or they did not receive strength training with infrared treatments. They all had the infrared heating, but only half the group had the strength training. They intervened for 6 weeks, and there is a significant difference, once again, between the strength training group on MCU and those who did not do any exercises. But we also saw a decrease in pain rating, a decrease in the disability score, and obviously the isometric neck strength went up. Here's a case study, or a research study, I should say, of military pilots. These were F-16 pilots. This study has been performed on F-18 pilots as well as helicopter pilots. And so there's more data that's out there. You can find that on our website. But in this particular case, they went through a 12-week strength training program 3 times per week. When you look at the difference in flexion over 4 weeks and the difference in the next 8 weeks, how much stronger they got, that's once again significant. But the key to this population is that a lot of times pilots come in with a relatively weak neck, and then when they're exposed to these G forces, and if they're landing on an aircraft carrier or taking off on an aircraft carrier, there's significantly more force that's placed on the spine. And if any of you are aviation nuts like I am, and you watch all these takeoffs, you always watch a pilot on an aircraft carrier put their head back into the seat and brace themselves, because they don't want that whiplash mechanism to occur. But for pilots, the injury rate and the neck disability rating is very high when they get out. For helicopter pilots, there's a 65% disability rating when they get out of the military. In the Army, for instance, if they have a helicopter pilot that serves for 16 years, they want them to serve 8. But if they serve for 16 years, their likelihood of having chronic cervical pain is greater than 65%. And with that comes a service connection. And that service connection means that the federal government pays them a disability per month for the rest of their lives because of their career as a pilot. So this population needs to be treated heavily with more strengthening exercises, and they're just not. They're not getting the proper strength training before they go into flight school. And a lot of the researchers that we talk to nowadays, they're saying that this needs to be done sooner. They need to be incorporating this before they ever get into a real aircraft. So while they're doing their simulator training, they can go into MCU training. So we're going to first assess range of motion using the MCU. And we're probably all very comfortable using a goniometer, maybe dual inclinometers to assess the motion. But here what we can do is we can isolate the individual where we're not getting any type of compensation. So if we look at lateral flexion, if we all were to just sit here and try to pull our right ear to our right shoulder, at some point we may get to a point where our left shoulder starts to elevate. And with the MCU, we have these straps that go over, which eliminates that compensation that can occur. For each individual motion, we can isolate just that motion, and we can accurately see how far a person can travel. AMA guidelines suggest baselines for each of the 6 movements, and that is all built into the software, and you can also create new range of motion targets. What's really key here is when you look at these graphs on the left side versus the right side, The left side data shows that each repetition was exactly 90 degrees. So this person performed very consistently with each repetition to the left. When you look at the curve, this is the movement through time, or the degrees through time curve. Ideally, what you want to see is a nice looking bell curve. If a person has a pain or an instability, a weakness within the cervical spine, as they start to travel through range, they may slow down, and you may see this graph start to flatline and then go back up a little bit, maybe as there's some secondary compensation that occurs. So by looking at the graphs, you're able to actually see, as a clinician, you can further see these small changes that are occurring through motion that you may not be able to experience if a person is just moving their head like this. And then you're going to get a direct comparison from the left side versus the right side. Another big thing that we need to make sure that we look at is the consistency of effort, especially if this is going to be a legal case. If a person has a disability or they're going to be challenging their condition within court, they need to show that they're giving good effort. And the COV, coefficient of variation, is also presented with every single one of these tests that we perform. After doing a range of motion assessment, you're going to give this one-page report to your patient, likely, just to show them where they stand. As we see there, we're very visual. We see that for flexion and extension, that's the top left graph. We see that the norms are going to be for flexion. It's going to be 80 degrees, and for this individual, they were only able to go to 50 degrees. So there's a deficit there initially. When we do a reevaluation, we can still see that underlying initial evaluation with the new information on top of that. So in this particular case, this is a follow-up evaluation. So we have 2 bits of data to go along with it. But you can look at the percent change, and that's going to be very important. So after 4 weeks or so, when you reevaluate, you want to see how much has a person objectively changed their motion. For strengthening, we're going to do an isometric assessment. We can measure up to 50 pounds, which the vast majority of people cannot come close to. We do have some rugby players that can get there, of course, some American football players, but not many people can get up to 50 pounds for each of these motions. We are going to do this in a neutral position to start with, and then we can do it in any rotated position that we want. A typical assessment is going to be at least 16 isometric tests. You could do really up to another 30 or so if you'd like. That's a lot, but you certainly have the ability to test in any position that you would like. There's comparative data that shows where an individual should lie. So if they're only putting forth 10 pounds for extension and the comparative data says it should be 17 pounds, we see that there is a significant deficit for that. Here we're looking at a isometric contraction. We're looking at 3 isometric contractions for flexion in a neutral position. And what we see is that the time to peak, if you look at that blue line, that time to peak should be, for a person who is giving good effort, that should be within 1 second. For a person who's giving more managed effort, you're going to see something like on the red line. The red line, the time to peak doesn't actually occur until the very end of the contraction. So we see that there's a little bit of an inconsistency that exists here, and that's why over on the right side, you'll see the COV is 17.7 and it's in red. Research tells us that the consistency of effort should be 15 or lower for people that are giving their best. And in this case, although the lines are relatively symmetrical, there is a difference in when a person is reaching their peak and what that peak is. So you're able to see all of this, and this is in a real-time basis, and it's all objective, of course. So there's no real guesswork that goes into the assessment. One of the most powerful pieces of paper or data that we can present to a patient or to any physician is our radar graph. The radar graph shows strength of this individual compared to what strength should be for a person of this gender, this age. And within all of these 16 positions, we're looking at strength, and we're also looking at pain. You may not quite be able to see on your screen, but each of these red ovals, that has a pain number associated with the motion. So if a person is in flexion and they're doing an isometric flexion movement and they have a pain level of 6, it will show up on that graph how much pain was experienced at that point. We also can see down on the bottom on the table, we can see what the current versus the previous data was. This graph gets really powerful when you have the first visit to the most recent evaluation. When you get a couple of pieces, you can see how this radar graph starts to fill in. That lighter blue, that's the real strength that a person is experiencing. So if you can see my mouse, this light blue line right here, that shows that a person at this point is meeting the standard of strength for all of these positions. And in fact, with left extension, while looking to the right, they actually are above where they should be. So now we've evaluated, what are we going to do? We're going to treat it. You can use the same device. We don't have to change setups. We don't have to move to another place in the clinic. We can do all of the exercises from here as well. There's a weight stack on the back where a person can change weight increments by every ½ pound. And you can really focus on the very minute difference. From day 1, you're at 1 pound, day 2, you're at 1½ pounds. So you can add or subtract very small weights as you need to. There's 22 default exercises that are already built into the system. You also have the ability to add your own. Once again, every 5-degree angle, you can create a new exercise. There are graphic display of every repetition. So going back to the idea of the bell curve, a person who is moving comfortably through range, they're going to have a nice smooth bell curve. For a person who is experiencing pain, it's not going to be smooth. It's not going to be a rounded curve. It may be more flatlined. But what you're also going to get here, if you've ever been on any of our BT presentations before, you know we talk a lot about work. Work is the quantity or how much exercise is performed. And you can see with each session how much work is performed. So if on day 1, I go through 40 degrees of flexion, but day 2, I go through 50 degrees of flexion, even though I'm using the same weight, even though I'm doing the same number of repetitions, my work output is going to be greater. So we're going to have progress reports. This is a treatment progress report. This is just 2 visits. We show on the left side the first visit versus the second, and that's looking at how much work was performed. Over here on the table, you can actually see that work number as well as the percent change. So you are, as a clinician, you're objectively with each treatment, you're able to look at how a person is improving. You don't have to wait another 2, 3, 4 visits to reevaluate to see, oh gosh, I don't know how they're improving. Are they improving? You can see that with each individual visit following the treatment exercise that you do. So we have some recommendations on how you're going to treat specific conditions. These are recommendations based on some of our resident experts who have worked with the BTMCU for years and who are experts in treating these specific conditions. So for the whiplash disorder, you're going to start strengthening the plane where you're mostly in neutral. That's where we're going to start. And then we're going to move to the rotated positions after strength is improved in neutral. You're only going to go maybe to mid-range. You can set the range or the degree of motion that you want. So if a person can only achieve 40 degrees of flexion, you can set the goal of it being 20 degrees or 25 degrees of flexion so that they just work in that range to begin with. For stenosis, you're going to be working away from the problem. Avoid extension. Avoid lateral flexion toward the side of the symptoms. For chronic neck pain, once again, you're going to be beginning in the neutral positions. Just go through the tolerable point of motion and then set that as your degree. With every repetition that a person hits the target degree, there's going to be an audible tone. If you set that degree, it will give that patient a cue of when they hit that point through range, which can be very, very helpful for you and very helpful for them. For fusion, you're going to wait a little bit longer before you start to actually treat this with the MCU. I want to make sure that there's good, solid, stable structure there. Typically, it's going to be about 6 months post-procedure. You're going to have limited range of motion, of course. Strength is going to be very poor. You're going to see on the isometric testing, that line is very, very low. And in fact, it may only be 3 to 5 pounds of force, which is not much, but you will see that they will be very weak to begin with. This is going to be a longer session, longer type of treatment program. It may take 3 to 6 months of MCU work to really get that person where you want them. Disc herniation with neck pain, anything to avoid aggravating the direction, avoid pain in the direction of, avoid movement in the direction of pain. Avoid flexion if the symptoms are made worse with bending of the head, and avoid extension if a person is more painful looking up. So in conclusion, don't be afraid to treat the cervical spine. We have so many clinics that we go into. Maybe they have some of our other equipment and they ask what we have. Is there anything that you have specifically for this condition? And we'll get into the subject of cervical pain, and clinicians are like, yeah, I don't want to treat that. Maybe it's just too much time, too much work. maybe there's too much risk associated with treating the cervical spine. So don't be afraid to treat it. Movement is how people get better. And we're all movement specialists. We know how the body reacts to strengthening, to motion, and we can use the modalities, we can use these other things to help, but we have to move, and we have to move functionally. In the technology, don't be afraid of using that as well, because it's actually going to be your guide. It's going to hold your hand through this process. We're going to have to make some clinical decisions as we move forward, but those aren't always going to be guesses. We can make objective decisions just based on looking at the data. From one visit to the next, we can see that a person, their work is improving. So, hey, maybe I can up the resistance the next time, or maybe I can increase the range of motion. So you're able to make these clinical decisions using objective data to help you through the process. The MCUs, every time someone looks at it for the first time, they're like, whoa, that's cool, that's unique, that's different. And when patients first look at it, they might be a little bit intimidated, but when they get on it and they start to feel how they're isolating these neck muscles because the straps are in place and the head is in a set position, they really start to learn like, oh, aha, this is a moment that I've never felt before. I've never felt my head move this way. So you can really help to educate your patient by using technology throughout this process. And objectivity, that's around the world. It doesn't matter where we go. You gotta be able to produce objective data. That's so important to the work that you're doing and to keeping your patient involved, engaged, and giving them the confidence that you're making them better. So that's all I had at this point, and we're going to open it up to questions.
Thank you, Jeff. Really good. Some very interesting points. Before we go on to the questions, I just wanted to pick you up on something. Excuse me. In terms of the normative data, I'm never a huge fan of normative data because what population did you get that information from? Like how do you kind of levelize that? I guess is that US data?
So AMA guidelines, that's the American Medical Association for Range of Motion. That's data with healthy, older, younger. That's just kind of a generalized norm. There's much more data, much more evidence-based info available for that than there is for the strength data. Strength data still is relatively new. There's really only been 3 big studies that have been done looking at where's the norm. Certain populations, for instance, when we take this data to China and Japan, sometimes we'll get the response that a Japanese person's neck is different than an American's neck. And we're all different culturally based on how we live, structure, larger, wider frame, all of that does apply. The strength data, we call that comparative data. There's a difference between norms and a comparative data. But the comparative data is going to be really helpful to just give a general ballpark. That's why it's a range. Give a ballpark of where a person lies. There are some people that their baseline is going to be here. The comparative data says that they should be here. But a person may only get from here to here. But that's only what they can do. But the important thing is that they're getting better, but they're more functional and their symptoms go down and their perceived rating of how this affects their life is going down as well. So we use that as just a guideline to help us through the process.
Okay, great. Thank you for that. So can you measure RFD, which I presume is radio frequency denervation? And if so, what is the sampling frequency?
That would have to be a question for our software engineer with the outputs that the load cells would put out. I honestly can't answer that.
Okay, yeah. We'll come back. We'll find the answer to that question and come back to you.
I'll let you write that down.
So this is a really good question. So were the training group participants trained on the MCU and measured on the MCU? So do they then have an advantage automatically over the participants who were not familiar with the equipment and would therefore measure stronger anyway?
So ask that one more time just so I make sure I understood it correctly.
So were the training group participants, were they trained on the MCU as well as being measured on it? So were they able to have an advantage automatically because they were familiar with how the equipment worked and what it felt like?
Yeah, good question. Okay. So the groups that were evaluated everyone was evaluated on the MCU isometrically. The groups that were treated on it, there was no training program. There was no 2-week familiarization process. It was after they collected the strength data, they then went on into their exercise program pretty much right away. Very, very little, if any, training would go along with that. But you're right, the more a person is exposed to something, there would be that that comfort level with the movement and knowing what to expect. So there would be slightly higher data.
Okay, great. And just going back to the previous one, so it was actually rate of force development. Have you got an answer?
Oh, rate of force development. Okay. The sampling rate, so over the course of the 3 seconds, and you can do up to, I think we've capped it at 10-second contractions, but that sampling rate is, you're seeing about 100 data points per second, maybe even more. But that line that you see, that rate of force development, it's real time. It's pretty spot on.
Okay, thank you. And got a question here. So is it possible, because of lockdown and doing no hands-on treatments, this person's neck problems have been allowed to manifest after the whiplash injury, which occurred 2 years ago?
Absolutely. We're seeing this for all types of musculoskeletal conditions. I can only imagine those people that have been dealing with neck pain and haven't been treated for the last few months, that these conditions have only gotten worse. Like I mentioned earlier, my mother-in-law, for instance, hasn't been able to receive therapy during this time up in Michigan. And I know in her case, her neck pain has gotten worse too. So this is a problem. This is a worldwide problem. And the sooner we can start getting people treated, the better.
Yeah, no, absolutely. And are there any absolute contraindications for using the MCU?
Yes, there are. There is neural torticollis, pregnancy, last trimester. If there is any malignancy within the spine, you certainly don't want to put that person on here. But there's not a lot of contraindications. Many patient populations who are weak in the cervical spine and have cervical pain, they would be good candidates for the MCU.
Okay, and some more practical application ones. So can you do rotation, and does the MCU keep the rotation harness steady on the head?
Yes and yes. Rotation, we don't measure isometric rotation because that's just a shear force on the cervical spine, but we certainly can do rotation in an isotonic treatment way. You can put a person, there's a pad that goes on the front and a pad that goes on the back, and as they rotate the cervical spine, the pads are right up against the forehead and they're braced at the back of the occiput as well. So a person's going to stay nice and stable within that halo, and they're able to rotate left, rotate right as needed. And they can rotate up to 90 degrees in either direction.
Right, and what is the maximum force that can be measured?
50 pounds is what the load cells are rated to.
So you mentioned that
rugby players be able to do that.
Yeah, how do you find that with the athletic population then?
So if you're familiar at all with American football, these guys typically are very strong, very big shoulders. They're carrying a helmet on their head, running, hitting. There's not a lot that can hit 50 pounds. We have a research site down in Georgia that they're using the MCU for football players. And from what I understand, very few have ever come close to tapping it out. And these are elite football players. So it doesn't happen often.
And how does this relate? There's a lot of press about concussion. Have there been any studies using the MCU? Has that been included with any of that?
There have been a few, yeah. So it's such a huge research market right there with concussions. And there was a study that was done about 8 years ago with the MCU looking at strength and how does that play into concussions. And that one showed that there's not really any reliable data. There's not really any data here that says that because you're stronger, that you're going to be less likely to sustain a concussion. And in fact, they actually found that some of the people that were stronger had a higher incidence of concussion. And the thought was that with greater muscle strength and muscle mass, muscle size, that people would be developing more acceleration and deceleration forces with that. That hasn't been accepted as the norm. Just this past July, here in the States, we had the National Athletic Trainers Association virtual conference, and there was some talk there about how neck strength is a good indicator of concussion risk, that those who had stronger neck strength were actually a lower risk sustaining a concussion. So it's a big open field. There's still a lot to be learned about this. And every year at every convention, we're going to be learning more and more about it.
And then you also mentioned about road traffic accidents and WADs from that perspective. Is there any, like from a litigation perspective, is the system used from that angle in terms of consistency of effort?
Yeah, actually just a couple of weeks ago, I was in a clinic that they're using this for legal cases. They have a couple of lawyers in the area who deal with motor vehicle accident specialization, and they send all of their patients to this clinic to be evaluated. The halo that I showed you, that is the important piece to the evaluation. That shows kind of where they are, as well as that COV, that coefficient of variation. In those cases where a person is maybe 4 months, 6 months removed from an accident, they're being evaluated and their coefficients of variation are very high, then those are people that are deemed by that case manager, that lawyer, as being those that are not giving forth their best effort. And that can certainly be used legally in the States, because there's a lot of data that shows that that COV needs to be 15 or less for a person who is giving good effort.
Okay, thank you. And what do you expect the ratios between flexion and extension to be?
Extensions are greater than flexion. I don't recall the exact number off the top of my head, but I think it's a 3-to-2 ratio. Extensors are bigger muscles. There's more of them than the flexors. Flexors are little guys, and then we have to rely on the deep ones. So the extensors should be stronger. And in the vast majority of the population, we see that they are, but there's a much greater ratio than 3-to-2.
Okay. And for a standard treatment, how long would you anticipate this would take for a clinic to go through?
For each visit, depends on how many exercises you want to do. If you only want to do flexion and extension, you're probably looking at 10 to 15 minutes. If you want to do flexion, extension, and then maybe at an angle, so if you want to do some 25-degree flexion to the left and 25-degree flexion to the right, you're probably going to be looking at, since there's a rotational component there, probably another 5 to 8 minutes. One of our clinicians who teaches our course, she'll do 30 to 45-minute sessions with the MCU. It's all up to you on how many you want to do, how many sets, how many reps, how long of a rest break you want in between. So you kind of drive that boat.
And the clinics, typically, do they include any manual therapies combination, or do they try to isolate them?
Certainly there's a place for it. Early on, when just trying to get a good grasp of the pain and how this is affecting an individual, there's going to be manual therapy involved, dry needling, shockwave, E-stim. Some people have TENS units. I keep one here on my desk. I use mine. Yeah, there's certainly going to be some other interventions that are going to be used with this. It can be used as a standalone. We certainly see that. But we also see plenty of people that will use this with something else, with another type of intervention.
Okay, great. Well, we've gone through all the questions. So is there any finishing note, Jeff, that you want the audience to take away from today?
Yeah, I think I hit it in the conclusions. Don't be afraid to treat the cervical spine. It's a sensitive area. There's a lot going on there, but this is a place that people need good therapy. They need good treatment. They need clinicians who are devoted and really want to work on getting them better. Just because they've had pain for 6 months, don't give up on them. It's going to take a little while to make them better, but stick with it, show them the reports, give them the data, just keep them motivated.
Great. No, well, thank you very much for that, Jeff. I really appreciate your time in presenting and preparing that presentation for us. So if you could just put it onto the next slide, please.
Oh.
It's not on there anyway. No, so we were going to talk.
Oh, yeah, I don't have it. Sorry.
So basically, we will send you an email. So we've got several events coming up. We've got one on performing arts, which is next Thursday. And then we've got some other ones in terms of talking about treatment of a breast cancer patient using another one of BT's technologies called the Primus RS. So we'll send you a follow-up survey. If you could please answer the questions on there, that really helps us to improve what we're doing. and make sure that we're addressing the issues that you want to be addressed. So once again, thank you very much, Jeff.
Thank you all.
Thank you to everyone for joining. Have a great Friday afternoon and evening and weekend, and we hope to see you on one of these sessions very soon.
All right. Thanks, everyone. Take care.